The venous insufficiency is due to an excessive transmural pressure, and the signs as edema, ulcer, and varicose vein are not specific. The insufficiency is due to an excessive transmural pressure, which is due to anatomic damages of deep venous network. These damages are two: incompetence and or obstruction. The transmural pressure results from the difference from the intravenous pressure and the extravenous pressure. This is the intravenous pressure, extravenous pressure, transmural pressure at the level of the microcirculation, and here at the level of the vein, intravenous pressure, extravenous pressure, transmural pressure. The intravenous pressure is the sum of three pressures: the residual pressure, the gravitational hydrostatic pressure, and the valvo-muscular pump pressure. The obstructions increases the residual pressure and the systolic pressure provided by the valvo-muscular pumps. The venous valve's incompetence impairs the dynamic fractioning of the gravitational hydrostatic pressure, is to say, when walking. The value of the pressure at the ankle varies with the posture: standing, walking, standing, lying, and elevating the legs, and also the normal venous system, the incompetence of the venous system, or the obstruction of the venous system. The residual pressure is provided by the arterial pressure through the microcirculation. To say, this residual pressure is fed by the arterial pressure through the resistance of the microcirculation. The obstruction increases the resistance, and so it increases the residual pressure, because you have the residual pressure is equal to the arterial pressure less resistance to the flow and resistance of the microcirculation. The drainage can be impaired by the excessive transmural pressure when the intravenous pressure is too high or the extravenous pressure is too low. For example, if the intravenous pressure is too high at the microcirculation level, the extravenous pressure is not strong enough to drain. So the drainage impairment results in edema, tissue suffering from accumulation of the toxic metabolites. You can see here edema, ulcer, excess of transmural pressure at the level of the microcirculation. The obstruction increases the intravenous pressure. At rest, and lying and elevating the legs, it is due to the residual pressure, and when walking, it is increased by the systolic pressure of the valvular pump, which explains the venous claudication. The, the obstruction can be compensated by the collaterality, so in decreasing the resistance and then the pressure, and then relieving the effect of the venous insufficiency. This is a case of a woman who had a previous obstruction of the iliac vein here, but a good collaterality with time, and the measurement of the pressure at the ankle is just slightly elevated, 20 millimeters of mercury instead of 15. So she's very okay and nothing to do. In some other cases, the obstruction can be only postural, which is the case in the May-Turner syndrome when it is just postural. It was demonstrated in normal patients by angiography who had obstruction of the iliac vein without any symptoms nor signs. Practically, it was demonstrated with the ultrasounds that this obstruction is just postural, because in the position of the venography and or the duplex ultrasounds, we can see a complete obstruction of the iliac vein, left iliac vein here, with here the artery, here the cava vein, and here the dilated and blocked left iliac vein. But when the patient is in semi-seated position, you can see the vein, iliac vein is open, and you can see here the flow, a correct flow in the caval vein. On another hand, it is mandatory to assess the proper responsibility of the deep venous obstruction for the venous insufficiency, particularly when associated to valve incompetence. For that, we should measure the residual pressure in the patient in supine position, where the hydrostatic position is quite null, and we just measure at this position the residual pressure. We use for that a cuff, and we measure the venous pressure as we measure the arterial pressure, but instead of measuring arterial pressure, we measure the venous pressure. And when we release, we measure the normal pressure from 10 to 15 or 20 millimeters of mercury. The deep venous incompetence doesn't increase the intravenous pressure in supine or in standing still position, but only when walking, because it impairs the dynamic fractioning of the hydrostatic pressure column. That means that measuring the pressure to assess the incompetence is useless, because it doesn't differ from normal in any position, but it increases only when walking, or we say it doesn't decreases as it would do it like in normal conditions. And you can see here in normal, standing, here, sitting, and lying, and elevating, the pressure in normal doesn't differ with the incompetence. But when walking, the pressure doesn't decrease as well as in the normal because the fractioning of the column of pressure is impaired. This is why in normal, for example, when you are standing still, the valves keeps open, and so you have no fractioning of the hydrostatic pressure. But when you walk, during the diastole, for example, the valves incompetence during the diastole are closed by the diastole of the pump, so fractioning here and here the hydrostatic pressure down to the 30 millimeters at the level of the ankle. On the contrary, when in case of incompetence here, when you walk, as the valves are destroyed and doesn't close during the diastole of the valvo-muscular pump, you have no fractioning. So the pressure remains too high. Remember that keeping in the standing for a long time is not normal, and it creates problems because the pressure here is about 90 millimeters of mercury, so too high. The hemodynamic value depends not only on the rate of each valve incompetence, but also on their location and number. The absolute value of the Doppler reflex time is not a perfect rating of reflex because it varies with the strength of the squeezing muscle, contraction, and valsalva. For that reason, a classification of Doppler reflex, which I called dynamic index, is proposed preferable to the just reflex time or Psatakis index. Here, for example, we have various incompetence. Here, normal. Here, total, partial in incompetent valves. Here, just a segment incompetent, and here all the incompetent veins of the deep system, and here just one incompetent here, a collateral. In that case, if you measure here at all this level the flow, you see that in normal it stops here. In partial reflux, the peak is not important, but it lasts very long. In case of segmental reflux, the peak is not very high and doesn't last long. In case of total reflux, the peak and the time is symmetric to the systolic one. In case of closed shunt here, the reflex time and peak is higher than the systolic. For example, here, during the diastole here, the flow here is fed by not only by this vein, but only by the the collateral competent vein. This is a closed shunt. Which is the rational treatments? First of all, we have non-invasive treatment that could be applied in any case, only or in addition to others. The posture in obstructed and or incompetent deep veins because it decreases the hydrostatic pressure column with supine and leg elevation. The compression decreases the residual pressure and the transmural pressure because it increases the extravenous pressure, and you can use both posture plus compression may be sufficient to treat. Invasive treatment only when posture and compression doesn't achieve sufficient clinical outcomes. You can decrease the transmural pressure, decreasing the residual pressure, which is the case with these obstructions, stenting, bypassing. In case of deep incompetence, we can repair the valve, create a neo valve, use a prosthetic valve, or deep Shiva procedure. Deep Shiva procedure consists of deep closed venous shunts disconnection and hydrostatic column fragmentation. And for that, we have a video to show you. Conclusion: deep venous insufficiency proper knowledge needs hemodynamic basis and duplex US expertise. Impossible if you people doesn't understand, doesn't know this basis. Conclusion 2. The deep venous insufficiency management needs proper accurate hemodynamic assessment in order to improve tailored diagnosis and treatment and to avoid as well over diagnosis and under diagnosis.